Hello everyone, hope you're all doing good. In this video, we are going to discuss about infertility. So, first let us discuss about the definition of infertility. I would like to define infertility based on the age criteria. So, let us keep the age 35 years as cutoff. If someone is having infertility, then before 35 years, it should be like they had unprotected intercourse for a period of 1 year and still there was no conception. Okay. If it's happening after 35 years, then we'll take this same timing up to 6 months only. Okay. So, unprotected intercourse and still there was no conception even after 6 months. Right. Now, we have two more definitions. One is primary infertility, where the infertility is seen in people who had no pregnancies at all. Okay. Then we have something called a secondary infertility, where infertility happens in people who had at least one prior conception. Okay. I hope the definitions are clear. You know now about what is infertility, what is primary infertility and what is secondary infertility. Now, we have two more confusing terms in infertility. One is fecundability. Okay. So, fecundability is about the probability of achieving a pregnancy. Okay. So, the probability of achieving pregnancy within one menstrual cycle, that is fecundability. Okay, remember, within one menstrual cycle. Okay, and if you take this fecundability, it is 20% for the first menstrual cycle they try. Okay, right. Now, there is also another term, that is fecundity. Okay. So, fecundity is all about the probability of having a live birth. So, the probability of achieving live birth within one cycle is fecundity. Okay, fecundity, right? Now, it is 15 to 20% of one cycle. Clear? Right. Now, so let's discuss about the history taking and examination in a case of infertility, which is very important. Okay. So, first we have to discuss about the patient's age. Then you have to ask about how many years of marriage life they have, that is duration of marriage. Then you have to ask about the duration of infertility. Then you have to ask about their menstrual history. Okay. So, menstrual history, what you have to know is whether the woman has ovulatory cycles or anovulatory cycles. Okay, ovulation is happening or not. If she has ovulatory cycles, then she will probably have regular cycles with pain. Second one, there can be mid-cycle pain as well, which will be associated with profuse amount of mucoid discharge per vagina. Okay. And what is anovulatory cycles? Anovulatory cycles, the most common condition we see in our daily life is PCOS. Okay. So, in anovulatory cycles, you will have infrequent cycles, scanty menstruation, and you will also have a period of amenorrhea. Okay, so this can be followed by a period of profuse bleeding as well. Okay, now suppose when she have infrequent cycles, what are the other possibilities you would? You have to also think about hyperprolactinemia as well as the thyroid disorder. Okay, fine. Now, you have to ask about dysmenorrhea history also to the women. When there is dysmenorrhea, it can be of three types. Number one is congestive or spasmodic dysmenorrhea, which is seen in a case of fibroid. Then you can even have Tubal dysmenorrhea. So, what is Tubal dysmenorrhea? Tubal dysmenorrhea is something which is having the pain before the cycle, during the cycle, and even after the cycle. Okay. So, this is seen during endometriosis, and finally, we can have congestive dysmenorrhea in cases of PID and endometriosis as well. Clear? Okay. So, these are the other conditions causing congestive dysmenorrhea. Now, let's talk about the flow of the blood during menstruation. The flow can be defined as heavy menstrual bleeding, and few causes of heavy menstrual bleeding will include fibroid, endometriosis as well as pelvic inflammatory disease. Okay. Now, after obtaining all this history, you have to go and ask about the past obstetric history as well. So, you have to ask about the history of miscarriage and MTP, then about the past medical history. You have to ask about the history of pelvic pain, PID, tuberculosis, diabetic mellitus as well as systemic hypertension. Clear? Right. Now, you need to ask about the past surgical history as well, whether any pelvic surgery was done. Okay. Then you have to ask about the family history, where you have to ask about the genetic disorder or any premature ovarian failure. Okay. Then one important thing about infertility is you have to ask about the coital history as well. Okay. So, when you ask about the coital history, you have to be considered normal when it is 3 to 4 days per week, right? Now, you have to ask about dyspareunia. So, this is the frequency, okay, frequency of coitus. When you ask about dyspareunia, there can be two types of dyspareunia which they can complain of. Number one is superficial dyspareunia, which is vulvovaginitis, and next one is deep dyspareunia, which is pelvic inflammatory disease and endometriosis. Clear? Now, the next one is, you have to know this term vaginismus. Okay, so repeating, you have to know about the term vaginismus. So, vaginismus is the involuntary contraction of the muscles around the vagina. Okay. Now I will tell you some of the conditions and what are the symptoms associated with, so that you will be getting a rough idea about some of the causes of infertility as well. Okay. So let us see the condition first and what are the additional histories you can get pertaining to each condition. Okay. Number one is pelvic inflammatory disease. So why pelvic inflammatory disease is important in case of infertility means because it can cause tubal block. Okay. It can cause tubal block. Okay. So the history you can get is you can have white discharge per vaginum, you can have fever, or you can have pain abdomen. Number two, it can be a sexually transmitted infection which is STI. So this can also cause a tubal block, and the history you will get is usually pruritus, vulva, history of dysuria, and you will also have genital ulcers. Okay. And next one is tuberculosis. Okay. So tuberculosis can also cause tubal block. Okay. What are the symptoms you will have in tuberculosis? You can have fever, chronic cough, and weight loss as well. Okay. Then the next condition is you can have hypothyroidism. Okay. Now hypothyroidism can cause anovulation. So anovulation due to hypothyroidism means it will be associated with other symptoms like intolerance to cold, hoarseness of voice, and then lethargy, and there can be a history of weight gain as clear. Then we can have PCOS, okay, this which is as such a cause of an ovulation again. So in this condition also you will have a history of weight gain, acne, hirsutism. Then you can also have irregular cycles. Okay. Now next one is hyperprolactinemia, which can cause an ovulation, and the symptoms it can present as amenorrhea, or there can be abnormal breast secretions which can be milk. Okay. Fine. Okay. Now we have seen some of the possible causes and some of the possible histories that has to be elicited in a case of female infertility. Okay. Now, while going for examination, you have to see the build of the person, whether it is obese. Obese means you have to again think about PCOS or hypothyroidism. Then if there is pallor, you will be soon thinking the woman will be having a heavy menstrual bleeding. Then if there is hirsutism, acanthosis nigricans, and if there is a history pertaining to PCOS, then you must be thinking about polycystic ovarian disease. Sorry, repeating. And examination shows hirsutism, acne, or there is acanthosis nigricans, then PCOS should be in mind. When there is abnormal breast milk secretion, what you would think? Yes, it is hyperprolactinemia. Then thyroid disorders will be having swelling and goiter in the thyroid. Clear? Right. Now, you have to know about the abdominal examination as well. While during abdominal examination, if there is a scar, then it is due to previous surgery. Okay. So, that is diagnostic, laparoscopic, or this might have been a surgery that have been done for a ectopic. Then you have to see the mass per abdomen, which may be a fibroid. Then if there is any tenderness, then you have to consider pelvic inflammatory disease. Okay, fine. Now, let's see about the gynecological examination per se, what you will do in a female infertility patient. First point, you have to check her external genitalia. Okay, so her external genitalia, you have to check for the hymen, whether it is intact or not. Okay, then we'll go for the per speculum examination of the vagina, cervix. Okay, here you have to check if there is any associated bleeding PV or discharge. And the next one is bimanual pelvic examination. Bimanual pelvic examination, you have to check for the size of the uterus. So, let us see what you have to check for uterus as a. So, it is the size, mobility, and then tenderness. You have to note in the uterus. Okay, and suppose if there is enlarged uterus, what would we think? What would be the possibility? Yes, again it is going to be fibroid, endometriosis, or adenomyosis. Okay, so it is fibroid, endometriosis, or adenomyosis that you have to think here. Right. Now, you have to check the mobility. If there is a restriction in mobility, there can be a fixed retroversion. Okay, so which is pelvic inflammatory disease. And then you have to check the fornices for the tenderness. Okay, which is also possible in your pelvic inflammatory disease. And finally, you have to check if there is any adnexal mass. Okay, if there is any adnexal mass, then it is due to endometrioma. Okay, which is endometriosis in the ovary. Then any tumor or any mass or cyst like that, something. Okay, right. Now, let's see how we are going to evaluate these patients. So, evaluation. First one is test for ovulation. Okay, so these are very important for you. So, what are the tests for ovulation? As such, it's a separate question. Okay, number one is basal body temperature. So, this happens due to the hormone progesterone. Okay, this hormone has a thermogenic effect. Okay, now what it will do is it will cause a 0.5 to 1 degree Fahrenheit rise in temperature, and mostly this is seen after ovulation. Okay, so basal body temperature rises by 0.5 to 1 degree Fahrenheit after ovulation. Okay, And why it's happening? Because the hormone progesterone. Because the hormone progesterone has a thermogenic effect. Okay, that's what you have to know. Next one is USG for follicular study. Okay, so how much of follicles we have to study that. So for that we have to monitor the follicular growth from day 10 to day 16. Okay, then you have to remember the follicle grows at a rate of 1 to 2 millimeter per day, and size of the follicle prior to ovulation is going to be 18 to 20 millimeter. Okay, so the size is also important. So this is one when you will be knowing that yes, this follicle is going to ovulate. Okay, and the growth of the follicle is 1 to 2 millimeter per day. Now you have to know about LH search. LH search often happens 24 to 36 hours prior to ovulation. Then this will be confirmed, repeating, this can be confirmed by using LH search, repeating, this can be confirmed by using LH urinary home kit, and this is possible only when the LH values goes above 40 milli international units per milliliter. Clear? And the next one is mid-luteal serum progesterone. Mid-luteal serum progesterone is done between the days 21 to 23. Okay, or otherwise in other words we can tell it as day 7 or 7 days after LH search. Okay, so here you have to know the levels. If the levels of the serum progesterone are more than 5 nanogram per milliliter, it confirms ovulation, and if the value is more than 10 nanogram per milliliter, then it means that there is adequate luteal support. Okay, fine. Now let's see the next point. So here we are going to check the cervical mucus. Okay, so this test is also known as Fern test. Fine. Now what we are going to do in a Fern test, we are going to take the cervical mucus and then spread it on a slide, and this is viewed under a microscope. Okay, so under the microscope you will be seeing something called as ferning. Okay, so ferning is usually seen before ovulation under the effect of the estrogen hormone. Okay, so estrogen is the hormone predominant before ovulation, right? So you will be able to see something called as ferning. Ferning is something like it will appear, the cervical mucus pattern will appear like this. Okay, and then ferning usually disappears after ovulation because of the action of the hormone progesterone. Clear? You have to know one term here, that is spin bargate as well. So this can also be used as a test for fertility period, because spin bargate is nothing but the stretching of cervical mucus up to 10 centimeter even. okay, up to 10 centimeter, and this happens again due to estrogen hormone, okay, prior to ovulation. Another direct test we can perform is endometrial biopsy, okay. We have so many advantages in doing this test. Number one, you can be able to find out the secretory changes of the endometrium after ovulation. Then you will be able to find out the luteal phase defect, okay, that is LPD, okay. What it is? Luteal phase defect. Now, what is this luteal phase defect again? So, luteal phase defect is a condition where there is a lag of 2 days between the endometrial histopathology and the cycle date, okay. Also, another point is that we can even rule out endometritis here, okay. You can find out whether there is endometritis or clear. Fine. Now, let's see about another important investigation you have to give about the hormonal assays, okay. So, hormonal assays should include your basal, FSH, LH, then a thyroid function test, which will be including your T3, T4, TSH, and your serum prolactin, and then your test for insulin resistance as well, okay. Insulin resistance, which will include your GIT and fasting insulin. Clear? Fine. Now, another group of investigations. So far we have seen the test of ovulation. Now, we are going to do some tests for ovarian reserve, okay. So, what are the tests of ovarian reserve? Test of ovarian reserve. First one, you have to check whether the ovary is responsive to whatever treatment you are giving or not, okay. So, what are the indicators for ovarian response? Number one, day 3 of AFC. AFC is nothing but the antral follicular count, okay. So, it is antral follicular count. You will have around 10 follicles of 2 to 10 millimeter, okay. That means you will have a normal response to the treatment you have given, okay. Number one. Number two is AMH. What is AMH? Anti-Mullerian hormone, okay. Now, anti-Mullerian hormone, it is usually strongly recommended with your basal. Now, routinely this anti-Mullerian hormone has to be done with your day 3 antral follicular count, okay. So, it can be measured on any day. Anti-Mullerian hormone levels, normal response means you will have a value around 1 to 3.3 nanogram per milliliter. Then, if there is poor response means you will have around 0.5 to 1 nanogram per milliliter, and then you will have hyper response means it is more than 3.5 nanogram per milliliter, okay. So, when you have this level, and then you will have a risk to OHSS, okay, that means ovarian hyperstimulation syndrome. Okay, ovarian hyperstimulation syndrome. Clear? Now, let's see about the FSH levels. FSH levels on day 3, that is more than 10 milli international units per milliliter. Okay, if you have, then it is, remember, it is poor response. Okay, and the next one is inhibin levels. Inhibin levels on day 3, when it is less than 45 picogram per milliliter, then also it is poor response. Okay, you have to understand this. And the next one is a group of tests to test the tubal patency, because that is also important. Okay, so test of tubal patency. So this is usually performed as hysterosalpingogram test. Okay, in short, we can call it as HSG test. Okay, so this can be usually performed on days 8 to 10 of menstrual cycle. Okay, now it will give the information about the contour of the uterine cavity, if there is any malformations, septa, polyp, or if you have to know about the tubal patency or block, or if there is a submucous fibroid. Okay, next is have to know about the saline infusion sonography. Okay, saline infusion sonography can diagnose polyp, septa, or septal block again. Okay, the next investigation we have to do is laparoscopy. Okay, so we all know laparoscopy is one procedure where you'll be able to find many things, right? So you'll be able to diagnose myoma or any uterine anomalies. If there is tubal adhesions, peritubal adhesions, tubal block, then fimbrial condition, hydrosalpinx. You can even find out if there is a PCOD or tubo-ovarian mass, tubomasses, tubo-ovarian mass, and then if there are any adhesions of the ovaries as well, then if there is abdominal tuberculosis, endometriosis also. Okay, you can do a methylene blue test where the dimethylene blue is injected into the cervical canal, and as you insert it into the cervical canal, it will be overflowing and it will be passing through the tubes. Okay, and it will be collected in the pouch of Douglas. So if this is happening means, what do you confirm? You can confirm tubal patency, right? So tubal patency is confirmed here, and laparoscopy is not merely a diagnostic procedure, but it is also a therapeutic procedure. Okay, you can treat it with other operating procedures, like you can combine it with adhesiolysis, ovarian drilling. This is done in a case of PCOS. Okay. So that's why we say it is both diagnostic and therapeutic. And another simple investigation we can do is hysteroscope. So in this one, we'll be able to visualize both the corneal osteas. Okay, so corneal ostia can be visualized. Then this can also be diagnostic and therapeutic. In this method, uterine septum, okay, if it is present, that is in the case of septate uterus, the septum can be resected as well. Okay, not only septal resection, it will be able to remove a submucosal fibroid or an endometrial polyp as well. Okay, so finally, if you ask me what is the gold standard of investigation in infertility, it is going to be hysterolaparoscopy. Okay, where we'll be doing a hysteroscopy followed by laparoscopy as well. Clear? Now, we'll come to the test for cervical and immunological cause. We have something called as post-coital test, or it is the Sims test, or otherwise it is also known as Horner's test. Okay, this is usually performed 1 to 2 days around the time of ovulation and 2 to 12 hours after coitus. Okay, what happens is we have to aspirate the cervical mucus. Okay, cervical mucus is aspirated and it is examined under the microscope. Okay, it is examined under the microscope. Here, if you have to see the number of sperms per ml, okay, there are 10 to 50 motile sperms, okay, that is present per high power field, okay, per high power field. Then it indicates there is normal sperm motility and there is also mucus penetrating capacity. Okay, fine. And the next one is presence of immobile sperms due to immunological factors. Okay, so that means it has anti-sperm antibodies or that we can check. Okay, and finally, postcoital test can also assess other factors like spin bar gait, ferning, and even the cervical mucus qualities what we have discussed. Clear? Right. The next one is semen cervical mucus contact test. Okay. Here what we are going to do is equal amount of semen and cervical mucus, okay, is going to be mixed. In the presence of antibodies, more than 25% of the sperms will show jerky or shaky movements by 30 minutes. Okay. Next is sperm penetration test. Okay. So, sperm penetration test is Miller-Kursrov test. Okay, it is also known as Miller-Kursrov test. Okay, so here what you have to do is you have to be placing the cervical mucus, that is around the time of ovulation, on a glass slide. Okay, alongside the husband's semen. Okay, alongside the husband or partner's semen, and then the penetration of the sperm is tested. And this will be done mostly under the microscope. Okay, now normal cervical mucus permits invasion by motile sperms. Okay, any penetration less than 3 cm at 30 minutes is considered to be abnormal. Clear? Fine. And the next one is, let's discuss about the management of female infertility. Management of female infertility includes two main concepts. One is general management, and the second point is specific management for the specific conditions or defects. Okay. Now, what and all you should include under general management? General management consists of counseling regarding the problems, okay, or the various therapies she needed, and you have to give her awareness about the conception window, okay, and it should also include her husband. And what are the other considerations you have to take into counseling is, you have to explain her the treatment cost, what are the possible results of a particular treatment that is afforded. Then you have to explain her about any side effects of the therapy as well. Okay, you have to also give them psychological psychological support and assurance. Then maintenance of BMI. Okay, ideal BMI should be maintained between 25 kg per meter square and 30 kg per meter square. So, management of other medical disorders including diabetes, thyroid disorder, then avoidance of anti-fertility drugs should also be given. Okay, so this is about the general management. Now, let's talk about the specific management. If you ask me, what are the things we have to specifically manage in the case of female infertility? The various conditions will include, number one is, you have to manage anovulation or oligo-ovulation. Number two, it is about the Tubal factor infertility. Number three is cervical factor infertility. Then your uterovaginal problems. Then it's about the immunological factors. And finally, some of the unexplained causes of female infertility. are also there. So these are some of the specific conditions you have to manage. Now, management of ovulatory dysfunction. Okay, ovulatory dysfunction in general, okay, it is treated by number one, for her general management you have to advise weight loss, okay, if there is obesity, and counseling regarding the diet management should also be given, and you can have medical and surgical management as well. Okay, so these are the three types of management